All right. Well, again, welcome everyone. It's Mitchell Warren from ALVAC, and delighted to welcome you to this webinar to get really the latest update on HIV vaccine research. As many of you will know, probably all of you will know, just a couple of weeks ago was the 19th commemoration of HIV Vaccine Awareness Day. And while that day has always been an important day to reflect on the progress and the challenges ahead in vaccine development, it's also been a chance to recognize and thank not only the thousands of trial participants, but the thousands of trial site staff and researchers who together with those thousands of participants seek to advance us towards the ultimate goal, which is to develop a safe, effective, and accessible HIV vaccine. Rarely, at least in my knowledge, in 19 years of HIV vaccine awareness days, have we actually had a chance to describe and hear about and announce actual scientific progress. And that was indeed the case just 2 weeks ago when important news came from the HIV Vaccine Trials Network. And I am incredibly delighted to have Linda-Gail Bekker from the Desmond Tutu HIV Foundation and the University of Cape Town and the HIV Vaccine Trials Network to give us much of that update in just a minute. Just to give you a quick sense of the day, Linda-Gail is going to present the slides are on the web, and we will be posting the slides and the recording later on the website. We will take questions. The line is mute for now. If at any point during Linda-Gail's presentation you want to type a question, feel free to do it in the chat feature on the ReadyTalk website, or you can do it via email at avac@avac.org, and after Linda-Gail presents, we'll be able to also open up the line and have people ask questions directly. I think anybody who works in HIV, period, knows Linda-Gail Bekker. Linda-Gail is one of the most energetic and enthusiastic leaders, both as a researcher and as an advocate. And for all of us at ALVAC, that combination of researcher-advocate is a wonderful combination. Many of you will know her from groundbreaking PrEP research and PrEP implementation. You will also know that she has been the leader of a number of vaccine trials, including the HIV Vaccine Trials Network trial HVTN 100, which is going to be described here in just a moment. And many of you will also know she is the president-elect of the International AIDS Society and officially takes over as president of the society in Durban later this year at the International AIDS Conference. So we're incredibly fortunate to have Linda-Gail on the line today from Cape Town, where it's always beautiful, I know. But Linda-Gail, I'm really so grateful for you to take the time to present to us. And if you are not yet unmuted, you can hit *7, but go ahead and I can advance your slides as we go.
Great. Well, can you hear me, Mitchell and everyone? Am I unmuted?
Yes, you are unmuted and
Terrific.
Very clear indeed.
Terrific. Well, wonderful. And thank you, Mitchell, for that warm welcome. And, of course, I'm delighted to be able to speak to the members present on this webinar. And the object, I think, of this afternoon is one to outline what HVTN 100 hope to achieve, what it has achieved so far, but even more broadly, what the UHAMBO project is, and what we hope to further achieve as we go forward beyond 100. So the talk will be quite broad, and I do preempt this by saying that we have put a late breaker into AIDS 2016, which I'm hoping everybody on this call has registered for. And so we will be showing the detailed immunogenicity, we hope, if we are accepted. We're waiting to hear whether we are accepted. And so I'm not going to show the detailed immunogenicity, but I will more broadly explain what has happened. And Mitchell, I'm always happy to come back after AIDS 2016 when embargoes are lifted and give more detail at that time. So as you see in our title, I like to think of HVTN 100 as the starter pack for the whole journey of hope, known as Uhambo, and where we are headed is towards an efficacy trial that will be called HVTN 702. And I present this data, obviously, and this whole sort of subject on behalf of the broader 100 protocol team, but also more broadly on behalf of the HVTN and the leadership of HVTN and the program as it is unfolding, as well as the P5. And I will explain who the P5 are in a moment. So moving to the next slide. I guess the next slide really just, and there has been a number of these modeling type efforts to show what the impact of a vaccine, an HIV vaccine, might have on the epidemic, the global epidemic. I'm pleased to announce that some of this work is ongoing, and in fact in Cape Town next week there will be again a discussion about the modeling that is required to really understand what the impact of a vaccine would be. But what you see here in John Stover's work is that even a vaccine that had limited efficacy but good coverage would have some impact, and vice versa. So, again, as good as models are, and obviously it all depends on what the assumptions are, this just begins to sort of unpack something that I've been asked by a number of reporters over the next little while is, how good does a vaccine have to be in order to have a significant global impact? And this is just some of the kind of work that has been done by others, and that the listeners can read more about. Moving to the next slide, this really illustrates where our story starts, and it begins with this, hugely courageous trial that was run in Thailand. It was reported in 2009, as you see in the New England Journal of Medicine, and it is rather now well known to all of us as RV144. And this trial really kind of turned on the light that an HIV vaccine was in fact something that we could contemplate, and that it could in fact be a concept that could play out. So you'll see the results in the next slide, and that shows the efficacy Kaplan-Meier, and you see in the modified intention to treat here a 31% efficacy over a 3.5-year period. So the study was, its primary endpoint was out to this 3.5-year end point, as you can see, and at that point, 31% efficacy. Merlin, Robb, and others went on to look at the time trajectory of the efficacy, the vaccine efficacy, and you can see that at this time point of much earlier, of a year or so, we do in fact see efficacy of up to 60%. So, when you look back over what was happening in the vaccine efficacy over time, you see that we had much better results earlier on. So the next slide really just illustrates that more clearly for you. That gives us even more hope that if we could work and build on these vaccine components, we may in fact be able to build on that and extend the durability as well as the potency of the vaccine over a period of time. So that, and this was said in the next slide by Dan Baruch, who wrote an editorial at the time. He said there are clear reasons for optimism in the quest to develop an HIV vaccine. And although modest, the results in the RV144 really are the proof of concept that an HIV vaccine is in fact doable. So this wonderful partnership was then born, and that's in the next slide just to explain the components of that to you. It's known as the P5, or the Protein Public-Private Partnership. And this involves the Bill and Melinda Gates Foundation, the HIV Vaccine Trials Network, the Division of AIDS at NIAID, Southern African Medical Research Council, and of course the vaccine component developers, as well as the military who ran the trial in Thailand. And the idea was to build on these results and ultimately develop a licensable HIV pox protein vaccine. So to unpack this a little bit further, and the next slide just kind of says it again, the idea of the next generation was to achieve same, if not better, prevention of HIV infection using these correlates of risk, and I'll come back to that, in order to really understand how to build the vaccine and ultimately to look for better and longer lasting protection. So this was branded for South Africa, and in the next slide I want you to become familiar with this term, uhambo, which is a local dialect, which means a journey of hope, and our journey is in fact a journey of hope to be free of HIV, and that's where we're hoping we will be going. So I'm now going to sort of in cartoon style explain to you what the next steps were. The first was to bring the vaccine components as tested in RV144 to the Southern African region. And of course here we, unlike Thailand where the clade that is circulating is BE, here the clade that circulates is overwhelmingly predominantly C. So the first thing was to bring that vaccine and to test it in our region, and that was called HVTN 097, and it's more clearly described in the next slide. And we tested the vaccine in 100 low-risk participants with the question of, will the population in South Africa produce the same immune responses that the Thai population did? In other words, are there host issues involved, or can we expect as good as or even better results? And those results have been shared by Linda-Gail, who chaired this protocol. And in fact, I can say in a word that the immune results that we saw were at least as good as, and in a number of cases better than what we saw in HVTN 097. So that really encouraged us to go on. And in slide 13, you'll see what the next step in the strategy was really now to take those vaccine components and make them compatible to the circulating clade that occurs in sub-Saharan Africa or in Southern Africa. And so the one component called ALVAC HIV-C or ALVAC HIV was reconstructed to take on this C antigen, as you see. The protein, the bivalent subtype GP120, was also remodified to now be a C, compatible with coming across viruses that are clade C. And the adjuvant that was used in Thailand was alum, and so we changed the adjuvant to MA59 in the hope of increasing potency and durability. In addition to increase potency and durability, a booster at 12 months was added to the regimen that was initially run in Thailand. So Thailand had 4 vaccinations. We now in HVTN 100 had 5. So if we can move to the next slide, really just a cartoon to show we took those vaccine components that were compatible with BE, and we have made them to look like clade C, or to be compatible with clade C. And moving to the next slide, we have in HVTN 100 taken those components and put them into sites in South Africa. So that really is the preamble to where we are. So what is 100? And in the next slide, we give you a title. It's a phase 1/2 randomized double-blind placebo-controlled trial of these 2 components. You see the ALVAC and the bivalent subtype C GP120, MF59 is the adjuvant, in low risk for HIV infection, HIV uninfected adults in South Africa. And this clinical trial is still ongoing, but we had a primary endpoint, which I will articulate for you in the next few slides. So the next slide really is our message to all of you today. And I'll come back to these predefined criteria, but it's important right up front to tell you why we're so excited, is the immunogenicity at this time point in the predefined criteria that we set. The immunogenicity has passed all of those criteria, and it really gives us the green light to move the regimen into an efficacy trial called HVTN 702. We have a DSMB that has been a data safety monitoring board that has been monitoring VTN 100 and will also monitor 702 when it does hit the field, and that board has agreed that the criteria have to date been met. The criteria were based upon immune responses that were found in RV144 and were associated with correlates of protection. While these criteria are not the only immune responses that are potential correlates of protection, the correlates that we did measure in HVTN 100 achieved sufficient prevalence and magnitude to recommend us moving forward to 702. So that's the big takeaway message, if nothing else, today. So in slide 18, I'm just going to remind you again, these are the components of our vaccine, and now, created to be compatible with Southern Africa, and that is what we have been testing for the last, 6 to 8 months. The next slide just gives you a little more detail about, for those of you who are interested, exactly what the ALVAC component looks like. And you can see that we preserved the link to the ALVAC HIV used in RV144, but it now contains this envelope gene from a circulating clade C virus, which was found in sub-Saharan Africa. And it expresses those various antigens that you see there, and it's injected intramuscularly as a single dose. The next slide describes to you what the protein is. It's a subunit protein, bivalent subtype C, GP120. It contains monomeric proteins, and you see them there, TV1 and 1086. Again, one found in Malawi and the other isolated in South Africa. And these are both delivered as half-mil IM injections. And they are combined with this MF59 adjuvant, a very well-known adjuvant. It's used in flu and a number of other vaccines and has been used in many, many thousands of people around the world. It's considered to be a very safe adjuvant, a very effective adjuvant. So moving to the next slide, it really explains the rationale of 100. So again, reminding you, it's a phase 1/2, which means the first thing we do is we wanted to be sure that it is safe. And the next was to look at its immunogenicity. So it's a combination of the two first-in-human vaccines. Although these components were tested in Thailand, this is the first time they're being tested in humans in their C form, reformulated as a clade C. In addition, it is now combined with MF59, and we have this additional 12-month boost. So if we move to the next slide, our primary objectives, as mentioned, are safety and tolerability. So we have our regimen, and I'll show that to you in a moment. But it's very important that we first, because this is the first time in humans, we want to be sure the vaccine is safe and well tolerated. And then we wanted to evaluate the immunogenicity at the peak immunogenic time point after the first 4 vaccinations. So that is the 6.5-month time point, because that is comparable to that kind of boost we saw in RV144, that time when immunogenicity looked very good in RV144. It's a comparable time point, and we wanted to make this comparison with RV144. So if you can just remember this 6.5-month time point, and if we move to the next slide, you'll see the schema there, that we have the 4 vaccinations at month 0, 1, 3, and 6. And then 2 weeks after that 4th vaccination, we take blood. And that's the blood that we are testing for immunogenicity and that I'll be reporting today. But it's important to know that we are ongoing with the study. We remain blinded. Participants are still actively engaged, and we are just at the moment finishing our 5th vaccination, which is that boost at month 12. Again, to point out to you, there are 252 participants in this trial. 210 are getting the active arm. We are all blinded, and 42 are receiving placebo as control. If we can move to the next slide, I'll explain to you the wonderful people who are leading fantastic sites in getting this study done. And you'll see them there. There's Craig Innes. There is Fatima Lahur, who is actually my co-chair and wonderful. There's Muku, there's Kathy, and there's Bonnie as well, who are all part of the HVTN 100 protocol. So if we move to where we are at the moment, just to remind you, we are still in study. But I'm explaining to you the interim safety and the interim immunogenicity, primary immunogenicity at 6.5 months. This is really to be able for us to say, should we move to 702 or not? And that's what I'll be describing to you in the next moment. So just a little bit more about correlates of protection, difficult concept, and so I'll unpack that in a few slides. And this is an important paper that if any of you want to really delve into this in more detail, you might want to read by Barton Haynes around the whole immune correlates analysis that occurred after RV144 trial results were released. And the concept here is that in clinical trials that show efficacy of a vaccine, the identification of immune responses that are predictive of trial outcomes generate hypotheses about which of those responses were actually responsible for the protection. And of course, if we wanted to determine whether a correlate of infection or correlate of protection is a cause for why that vaccine is efficacious, it must be tested in additional clinical vaccine efficacy trials, or indeed could be tested in animal models. So after RV144 was completed, a number of bloods were sent across the world to a number of labs to say what was the important biomarker that gives us a clue as to why this vaccine was efficacious. And if you go to the next slide, some of the most recognized and discussed correlates of risk or correlates of protection. Correlates of risk are really the antithesis of correlates of protection, were given in the RV144 trial. So you see some of them there. A negative or a correlate of risk, if you like, was the presence of IgA antibodies to envelope. But a protective concept was the presence of these binding antibodies to the V1, V2 loop. There have been other studies that have now come to pass, and this is a paper by Lin and others more recently. The BART paper was 2012, but this is a more recent paper in 2015 that describes the functionality of the CD4 T-cell responses and suggests that, the more functional or polyfunctional these CD4 T-cells are, the better the vaccine is. And so these are some of the things we have been looking for in HVTN 100 so that we can say we expect to see as good as or even better results down the pike. So in the next slide, again, just further descriptions for those of you who really want to get into this in more detail around some of the additional correlates of risk in RV144. And in the interest of time, I won't go into all of them, but just to say there's a number of these that are important. This slide explains exactly what we did with HVTN 100. So if you can imagine, we took the bloods of the participants who participated in 100 at 6.5 months, and we have matched them with bloods that were archived from RV144 at exactly the same time point. So these are bloods that have been in the freezers, frozen, at a high temperature to preserve them. we've matched them for gender and age, and we've taken those and we've run these assays. That's the list of assays contemporaneously in the same labs, performing the same correlates of protection assays. And we've asked the question, how has VTN 100 performed compared with RV 144? And the next slide helps us just understand what some of those criteria are. And I've tried to sort of re-say them in ways that I hope everybody will understand. So there were 4 main criteria that we looked at. And the first was to understand the take of the antibodies to vaccine envelope. So in other words, the number of individuals who actually showed antibody responses to those vaccine envelopes that we'd already shown you are components of the vaccine. So we needed to reach a certain level of antibodies that was required as a correlate of protection. The second was to look at the magnitude of the antibody response in individuals. So how big was that antibody response in every individual across the participants from 100. The third criterion was to look at CD4 T-cell response take to the vaccine envelope. So now the first 2 are about antibodies, which is humoral response. The third is about the T-cell. So we're now talking about that other component of the immune system, the CD4 T-cell response. And we needed to see an adequate response across all participants in HVTN 100. And then the fourth was this incredibly intriguing correlate that came out of RV 144, which is the prevalence of these IgG antibodies to the clade C V1, V2 loop, which is a component of the virus. And we wanted to see an antibody to that particular loop, and it needed to be present in sufficient quantity for us to say that we had achieved the correlates of protection. We go to the next slide. This is somewhat perhaps confusing, but what it really is trying to explain to you is that we were able to model these correlates of protection and map out what RV144 looked like over time and what actually transpired, and then take an imaginary vaccine efficacy trial where if we manage to get the same response to the V1, V2, so if we manage to get the same greater than or equal to 63% response of antibodies to V1, IgG antibodies to V1, V2, then we could actually push out the vaccine efficacy in a way that you're seeing in the bottom graph. So we would actually get that durability and that increased potency that we're really looking for. So this is a modeled kind of teaser, if you like, of what we hope might happen, given that we've seen this response at the 6.5 month time point. But this is obviously all clever mathematical modeling to help us understand. So the next slide very happily sort of concludes where we are at the moment. The first is, very importantly, we have not seen any safety concerns with VTN 100 to date. The 5th vaccinations are currently ongoing, and our participants are all very much still engaged at sites. But importantly, cellular and humoral immune responses in HVTN 100 meet all pre-specified criteria to support the evaluation of this regimen in 702, which will be critical to defining the correlates of protection of this regimen in our region. And that these data indicate that the level of immune responses to these key immunogenicity markers will allow assessment of correlates of protection in the HVTN 702 design. So, obviously we're hoping we're going to see the vaccine efficacy that will allow us to talk about, a vaccine that could be rolled out. But at the very least, we are going to be able to, again, look at these correlates of protection and understand what the role of them are in our communities. So the next slide is really ongoing remarks, and this was said by Larry Corey. Dr. Corey heads up the HIV Vaccine Trials Network, and I think it really does explain the last incredible 4 years, the amount of effort that has gone to create a new vaccine regimen, to carry out the correlates of protection studies, and for these numbers of partners to come together to get us to this point. HVTN 097 now complete, HVTN 100 well on its way, and we are contemplating 702. And Larry said, that it's been an unprecedented scientific effort. New understanding of regions of the HIV envelope have been largely ignored, and non-neutralizing antibody responses, as well as the role that CD4 T cells play, have been perhaps overlooked. And RV144 has been so important for bringing us back to this point. And so we really do need to understand whether vaccine efficacy will be achieved by these efforts. And in order to do that, we want to move into a vaccine efficacy trial. And the next slide, many of you will have seen that on Vaccine Day on the 18th of May, this press release was released by the NIAID to say that, in fact, we have a go-ahead to move towards the vaccine trial, which will launch in South Africa. So just to give you a sense of what that will look like, the regimen will be very much as it was in VTN 100, but now the primary objective will to evaluate the vaccine efficacy of this regimen in HIV seronegative South African adults over a 24-month period. And of course, we will also, as a primary objective, be looking at the safety and tolerability of that regimen. And the next slide shows you the schema in detail. It also explains that we will be enrolling 5,400 individuals in a 1-to-1 ratio of 2,700 receiving the active vaccine, 2,700 receiving placebo. And it will be the regimen that we just carried out. And in the next slide, you'll see that there are many more clinical trial sites that will be required. Those who've participated in 100 will be included, but of course we'll have to add a great number of clinical trial sites. And we're very proud that there are clinical trial sites that to date have not been part of this. And perhaps one of the most exciting is that the Eastern Cape will now be involved, which hasn't been involved before, as well as a number of new clinical trials around South Africa. So the VTN and partners are working very hard to get us up to speed to really be able to enroll this number of participants. The next slide is just again to remind everyone, none of this work gets done individually, but perhaps most important of all are the wonderful participants who've already participated in 097, in 100, and we're looking forward to terrific participation in 702, and then of course the 16,000 people who took part in RV144, which really got us going on this journey. And my last slide is really just to remember that a man who needs no introduction, his name is cut off there, I just see that, but of course this is our very dear Archbishop, who says that, along with science, we need the activism. So it is my great pleasure to say that I think the science looks solid. We're very excited, and we also move into this next phase with a great deal of optimism and activism, believing that we are on a journey of hope. Last slide is really just to thank many people, and this is the fantastic 100 team, and then beyond that, the number of, and especially the laboratories. People have worked literally through weekends, and the statisticians have done the same, so that we could get the data out and start the process of moving towards the efficacy trial. Of course, the funders, the vaccine developers, the people who've worked so hard to get vaccine on the shelves so that we could do these trials. And I'll stop there and listen for any questions if I can help.
Great. Linda-Gail, thank you so very, very much. That was terrific. There are a number of questions that have come in, and please, people, keep sending them in via either the ReadyTalk chat or via email at avac.org. And in just a moment, I'll invite people to unmute by hitting *7 and asking any questions of Linda-Gail. I would ask that you remute by hitting *6 just to keep the line clear. But Linda-Gail, thank you so very much again. A couple of questions came in straight away, and maybe I'll just get started with those before we see what else is on the line. One that came in described, you described very nicely how the transition from the original finding in Thailand with the subtype of HIV BE and then transitioning it to the subtype C in South and Southern Africa. But a question came in from actually a colleague in East Africa asking basically, what about East Africa and what happens not just in East Africa, but should 702 see a higher degree of efficacy and eventually move to licensure? What does that mean for non-clade C regions, and how would one think about that and go about addressing it?
So thanks, Mitchell. It's a great question, and it's a very important one because obviously, this is a global epidemic, and whilst the attention seemingly appears to be only on the clade C region, we are, of course, very hopeful that this is going to have great cross-clade potency. I think in terms of trying to, as you know, in a vaccine or in any efficacy trial, you want to give the product the best chance in order to get the efficacy readout. And some of the recent PrEP studies, I think, have really brought that to light, that you do, if you're testing a product, you want to give it its best chance to be able to establish efficacy. And then from there, many other trials can follow. So I think what we are very hopeful is that this study will give the product its best chance, but then thereafter, bridging studies should be relatively easy to do, particularly if we have correlates of protection. And that means we wouldn't have to conduct the whole vaccine efficacy, whole 3-year thing again, but actually be able to bridge to a number of populations to the north, to the east, populations in other regions of the world. Obviously, to adolescents, that's a very key group. Pregnant women would be another very important group. What is, I think, is exciting and perhaps, a reason to be optimistic was seeing the very nice cross-clade potency when we took the BE and put it into a subclade C region. So, and we are currently running immunogenicity on the RV1 on the HVTN 100 samples to look for that cross-clade activity already. So, I do think we have a plan for that. This would not only could only stop in South Africa, but go beyond.
Great, thanks so much, Linda-Gail. Another question came in, and I will go ahead and ask it, but I think that some of it, as you said up front, some of the more detailed data that was collected on which the decisions have been made, you're hoping to present at the International AIDS Conference in July in Durban. But maybe you could clarify just a bit. There was a question about the pre-specified criteria, and someone asking about if each individual met each of the 4 preset criteria, and if so, what percentage of individuals. But I know that each of the 4 criteria are quite different. So I wonder if you could just maybe, without getting into the detail of each of the criteria, about how those criteria kind of play out in what you saw and in what the trial will look like going forward.
Right. Well, I think what and perhaps it didn't come across as clearly, but what I tried to point out is that there are a number of these correlates. So whilst the trial has kind of honed in on what consensus drove to sort of articulate 4 sort of main criteria, there are a number of different biomarkers that are actually sort of continuing to come in. And I'm sure, as we write the HVTN 100 paper and as more data comes out, I think people will see that it's much broader than just these 4 criteria. But I think we needed something to sort of hang our hat on, as it were, again, it was very much consensus-driven around these were key. How many people had the right antibody responses? How big were those antibody responses? How many had the right T-cell responses? And did we see this action with the V1, V2 loop, which seemed, very important in RV144? So and obviously there are some statistics involved. In some cases, we needed to be as good as or beat what we saw in RV144. In others, we had to actually, reach a particular benchmark, a certain level. And so that detail I will almost certainly be describing if I manage to get a late breaker, but either way, I'm writing the paper at the moment, and so that data will be coming out. We just don't want to mess up any embargoes with scientific meetings or papers in order to do that. But just as, I think I can say that and suggest that detail will be following soon.
That's great, Linda-Gail. I did put back up the slide here about the predefined criteria, so it wasn't as if each participant is judged on each. It's the data analysis across the whole trial and compared to the RV144. So actually, one of the issues that's not yet known, and I wonder if you could just clarify, a question came in about the booster. You talked a lot and rightly about the desire to do better than Thailand and this idea of adding that 12-month booster. And if you just, as someone asked if you could just clarify the time frame, and you said something that HVTN 100 is still ongoing, and not all participants have received the booster. Is that correct? And what is the time frame of that relative to the starting of 702?
So these immune responses that I am describing is across the board in all of them at 6.5 months. So it's just after the 4th vaccination. So we haven't looked at the immune responses after the 5th vaccination, which is the boost. Because remember, RV144 didn't get the boost. So we don't have a comparator in RV144. We will obviously be collecting those bloods. And we will report them when HVTN 100 comes to an end and we unblind the participants. But we are obviously very hopeful that by giving the immune system another, if you like, shove from behind at 12 months, that we actually will just increase that durability of the immune response and push it out a little bit further. So that again, it's all experimental, and everybody will understand this is our science in the making. The notion is that booster is going to be very important for a durable response. So it's the same. Just to say, it's the same 2 components with the adjuvant in a 5th shot 6 months after the first 4 primary immunization run, if you like.
And you're still seeing participants in 100 even as you prepare for 702, correct?
That's right. Correct. And that is because I think, as everybody will know, there's a real sense of urgency. It's taken us a long time. It depends. Everything's relative. You can think of it as being a long time since RV144 came to an end. After all, we knew those results in 2009. But also it's been an incredibly short time when you think of all the work that has gone on to get us to this point. Whole vaccines had to be made and sufficient lots to be able to run these vaccine trials. So it's been an extraordinary amount of work to be done. But at the same time, it feels like a long time that we've known we had a pathway, as it were.
Absolutely. There were, actually thinking about pathways and next steps, there were some forward-looking questions, and actually one historic question thrown in. Thinking about these large trials that are such an incredible undertaking by the research teams as well as the participants. So one question came in asking about what might happen still in the future in Thailand, where the original, as you rightly said, 16,000 Thais participated in the original RV144. If you could give any sense of an update of what might happen in Thailand with respect to follow-on studies. And then a related question about what comes after a trial. Looking ahead, someone asked a great question about if 702, as you take it forward, if it does show efficacy and were to get a high enough degree of efficacy to move forward into licensure, what might be the post-trial access plans, not only for the people in 702, but would the participants in 100 actually be called back in years later and be offered that given their contributions? I wonder if you could maybe address some of these related questions about contributions to science from trial participants.
So let me say that RV144 has its own pathway, absolutely. The MHRP team, the U.S. military who run that program and actually ran that clinical trial together in partnership with the Thai government, that program has a whole pathway of its own. And so there have already been a number of fantastic trials looking at a boost in the people who were involved in RV144 and following up with them, as well as a sort of a reconfiguration of the vaccines out there, as well as a number of other vaccine products coming into the field. So just to say that the military are still very involved in partnership with Thailand and are moving along very nicely. But we are constantly, as you hear, sharing ideas and even sharing specimens in terms of trying to understand the two programs as they run alongside each other. So there is much more detail to be got from looking at websites to see what in fact is going on down there. In terms of the forward thinking, of course, that is very important. And just to say that ultimately there are a number of stakeholders that have a say in that, and obviously the regulators are key. I'm pleased to say that we've had an ongoing conversation with the Medicines Control Council in South Africa. They're very much engaged in this process, and from day one, the conversation has been around access and what that will look like. So we're not entirely sure when the chips are down, and obviously there's a lot of unknowns at this point, what will be required for licensure, although a number of scenarios have clearly been discussed at various times. And so just to reassure the person asking that question, the question of access is very much on the agenda from day one and has been raised by the regulators. The product makers are very much in the conversation, and clearly should we be allowed to license based on this study, then the whole urgency around product access will be very much on everyone's minds. But we're needing to clearly see what that vaccine efficacy looks like in order to take that forward. But we do want to plan for success.
Fantastic, Linda-Gail. Thank you so much. That's actually a great segue. This next question may not surprise you. It came in from a number of different people. And a question about access, but not as much about the future of the vaccine, but about oral PrEP. And you have been at the forefront of both PrEP research in South Africa and globally, and on building out PrEP delivery, both for gay men and other men who have sex with men, as well as for young women at risk in South Africa. And a question came up, and I know you saw this a lot already in the announcements 2 weeks ago. What is the plan for the offer of oral PrEP within the conduct of HVTN 702?
So I think, our stance on this, and as prevention trialists, prevention activists, prevention advocates, as you know, is that we really do want to see the best offer of prevention to all of our participants as required. So like so many of these things, it's complicated in that the field is moving incredibly fast, maybe not fast enough. But we do know that South Africa is really at the forefront of engaging around access to PrEP. We are closely engaged with government and with other players in this regard. We really do want to offer the best standard of prevention to participants, but we also need to be very mindful that we don't, in that process, do harm or do the wrong thing. And so the principle here is that we will offer and we will be in step with the standard of prevention that is on offer in the country, and we are obviously advocating strongly that that should include oral PrEP. We're working very closely with government to understand what that should look like. So at this point, as people know, PrEP is available to sex workers in the country. There is PrEP available in demonstration projects throughout the country. Those demonstration projects are gearing up. We've got some wonderful what you might call a bridge to scale kind of programs coming. I myself am involved in a number of those, and a number of the people working in this field are similarly. And I think we're going to be seeing where all of this aligns as the time for 702 draws near. So it's very much on our mind. We will certainly make sure that people are aware, and we are doing everything we can to ensure that the very best standard of prevention is offered, whatever it is in the country at the time. It's important for us to stay in step with this country, and to be working with the people who really, I think, are trying to do the best thing for South Africans at large.
Great. Thanks, Linda-Gail. Obviously, it is such an important topic, and one that will continue to evolve by the time 702 begins later this year. Undoubtedly, the PrEP dynamic will be different then than it is now, and certainly over the course of a 4-year trial, it will continue to change as well. Let me then just pause and see if people do want to hit star. There are some other questions, but I do want to take some time before we get to the top of the hour. If people want to hit star 7, I would ask that you introduce yourself, ask the question very briefly, and then remute yourself with star 6.
Hi, can I ask?
Yes, go ahead.
Lillian from Nairobi. You've mentioned the provision of PrEP in this trial. I'm wondering how this will affect analysis of efficacy results. Was this included in the design when you were, in the initial stages of designing the trial, so that you maybe planned for that?
I think, we've considered, thanks for that question, we've considered all scenarios. So we've actually considered a fairly broad, obviously whenever one does an efficacy trial, you power your study on assumptions around potential incidence in the population in which you are moving to. So some assumptions have been made. We have allowed for an optimistic and if you like, in a more pessimistic, higher incidence versus a lower incidence in the powering of the study. That is correct.
Great. Thanks, Lillian, and thanks, Linda-Gail. Other questions? Star 7 to unmute your line.
I don't want to dominate, but I still have another question, Mitchell.
Okay, go ahead.
Linda, you mentioned you'll be looking at, I think 5,000, if I got the number right, 5,400, or did I get the number wrong, of volunteers?
5,400, correct.
Yes. I'm wondering, because normally efficacy trials target populations most at risk, are there any specific target populations you're looking at? When you say men and women aged, you say 18 to 35, right?
Yeah. So, I think we very much leave this to, obviously there are some defined eligibility, so people have to be between certain ages. So in this case, it's 18 to 35. And so because the main mode of HIV risk is sex, we are targeting a sexually active population, and we are targeting adults because clearly until we know that the vaccine is efficacious, we would test it first in people who have majority before we move into the more vulnerable minority. It is men and women, and we really are asking sites, and sites have been chosen because there is a relatively high force of infection already in the areas in which they're working. So, clearly one has to conduct these studies in a way that they will be efficacious and successful. And so it's been a combination of selecting sites where there are excellent researchers and excellent resources and skill sets, but also where there is sufficient force of infection that in fact one expects to see some transmitted virus occurring, just because that is the world we live in today. Having said that, of course, we will, as I've already stated, will be promoting the highest standard of prevention that we can in every single clinical trial site.
Thank you.
Mitchell, this is Lisa. Can I ask a quick follow-up to that?
Yes, go ahead.
Hi, Linda-Gail. This is Lisa Rossi. Just, are you going to be trying to enroll a certain number of MSM? Are you going to be looking at, risk of anal sex versus vaginal sex in your population?
But he said, as you know, in all of these things, we always ask these in our risk questionnaires. And so there is a baseline. I think we ask risk questionnaires at least 3 or 4 times throughout the study. So that data definitely will be coming up. We are not specifically stopping any modes of sex, recognizing that some women, as you well know, also virus can be transmitted via an anal route in women as well. So we are open to all of the above, and the idea is to see if this vaccine is efficacious in people, as opposed to any particular segment of the population.
Great, thank you.
Great, thanks. One other question, well, actually 2 more came in, and I realize we're at the top of the hour, but I know most of you are still on the line, which is wonderful. One question, you had talked about within RV144 and the initial finding, one of the pieces that was surprising was this idea of a non-neutralizing antibody. It's on the call, I wrote in and said, they've been trying to get their head around all of this new research on neutralizing antibodies, and of course the start of another big trial, the antibody-mediated prevention trial, looking at whether the neutralizing antibody provides protection. And you described the potential of a non-neutralizing antibody. So I realize it's late in the call, but I wonder if you could give a quick sense of the distinction between those 2 antibodies, and maybe also relate to, as you and other investigators get ready for both of these studies, both the antibody-mediated prevention and the vaccine trial in 702, how you might be communicating these differences at the community and policy-making level, because these are such complex scientific ideas.
Yes. So as you say, in a few minutes, difficult to really sort of get into the depth and breadth of this. But I think what what the message is that these are in a way two different approaches to getting to truth and to where we need to be. So on the one hand, we've worked back from a vaccine efficacy trial. So we have some efficacy, we've gone into that trial, and we've figured out what some biomarkers might be that could suggest why that vaccine worked in that circumstance. And it turned out that a strong correlate of protection was around these non-neutralizing antibodies and their presence and their sort of breadth and depth to a particular envelope antigens. And, that, as you say, might be somewhat surprising. And it may be that it's this combination of what one sees with the T cells and how polyfunctional those are, together with those antibodies coming together in a particular mix of vaccine components that has given, enabled us to see that 60% at 12 months and indeed a modified intention to treat of 31% at 3.5 years. So, so now we're taking it to the next step of saying, can we put that back into a trial and then get out the correlates of protection again? So it's iterative science going on. The other strategy has been to say we do believe that neutralizing antibodies are important because, we've got a number of other infectious diseases where the neutralizing antibody action has been what has really kind of created a prophylactic vaccine and enabled us to control that particular vaccine in a human a virus or infectious disease in a particular host. And so the strategies come from the other side where we said, okay, let's take a neutralizing antibody that we know has been effective in an infected person. Let's kind of redesign it and turn it into a vaccine and then put that into people. But before we get to that point, let's be sure that neutralizing antibodies actually do protect against HIV, because although we've got good plausibility for that from other infectious diseases, we want to confirm that in human beings and with the HIV virus. And so that's exactly what the AMP study is trying to do. It's saying, okay, does this neutralizing antibody do what we want it to do? If indeed it does, then the next step will be to say, okay, how do we make that into a vaccine? And, just as we are finding with PrEP, as we found with contraception, we need more than one tool in our toolbox, more than one arm in our armamentarium, whichever your favorite analogy is. And that's where we're going with vaccines. We're saying, let's not put all of our money down on one horse. Let's be sure that we have more than one pathway or one mechanism in the works. And that's exactly what AMP is doing. Just to say that there are other vaccine programs. Johnson & Johnson has a wonderful program also on the way. So this is not the only vaccine program that has, a very optimistic outlook. And so, if people have not known it yet, I'm telling them again, we are in the midst of a prevention revolution. It is a very exciting time for us to really grapple with prevention. And, I think oral PrEP is a wonderful breakthrough, but I'm also very, very excited that I think we're going to be able to have a number of options available for those people in whom oral PrEP just isn't the answer, or for someone who a vaginal ring just isn't the answer. I think with these efforts, our chances of shutting this epidemic down forever really are very much improved. So those are, my sort of closing thoughts.
Great. Linda-Gail, so helpful and so important. I think you have in the research world and in your own advocacy done what so many of us in prevention advocacy have tried to do. You've done it as an investigator studying oral PrEP and the vaginal ring, and you've been involved in the trials of long-acting injectable ARVs and multiple vaccine studies and the antibody-mediated prevention, and not one of them replaces any of the other. And I think all of us on this line who've stuck with us and stuck with you for over an hour and will stick with you for the years to come would would confirm that. I did want to say it goes back to your very, very first slide, in fact, and why this conversation is so important today. As many of you may know, just earlier today in Nairobi, UNAIDS issued its latest epidemiologic update in advance of the UN high-level meeting. And there is terrific news on the one hand, in that it showed that by the end of 2015, over 17 million people were on antiretroviral therapy out of the global total of 39 million, still leaving a big treatment gap, of course, but seeing terrific progress to get to 17 million. Very sadly, though, that report highlighted why this call and why this research is so very important. What they reported today was, in fact, unlike in past reports, they're seeing no decline in new infections globally. And that is the reminder why, even as we all advocate to scale up treatment, we cannot rest with treatment alone, and why advances in circumcision and oral PrEP need to be acted upon, and why the research that Linda-Gail, you've described over the last hour or so remains at the forefront of the research agenda, because clearly our prevention efforts are falling way behind when we don't see any diminishment of new infections. So a sad reminder today of why this work is so important for the years to come. Linda-Gail, thank you so very, very much. There are some additional questions that will continue to get asked over the next many months as this 702 trial gets underway, and that we'll all be grappling with going forward. But I did want to thank you. I don't know if you have any last closing comments?
Not at all, just to thank everyone for being so interested. I look forward to seeing many of you at Durban 2016, and Mitchell, you couldn't have said it better. I look forward to continuing to walk this journey. I'm hoping, that the journey will be short, that we'll get to where we need to be as soon as possible. So thanks to everyone.
Thanks again so much, and a great reminder about AIDS 2016 in July in Durban, South Africa, 16 years since we all gathered in 2000, and we hope that this year's conference sets us on the right path, as did the 2000 conference. And also, I know many more of these conversations will happen there, and also just to remind people, also in October in Chicago, the Research for Prevention Conference, where undoubtedly the conversations about HVTN 100 and 702 that will soon begin after that, as well as the other vaccine programs and the antibody-mediated prevention, will all be major features of that meeting in October in Chicago. So multiple opportunities for all of us to gather as advocates, as researchers, and as partners in advancing this. Linda-Gail, thank you so very much. We will be posting a recording of the call, so if people either missed parts of it or want to share it with colleagues, please do, and that'll go up in the next little while, and we'll send an email around to remind people. And if you do have additional questions, I know Linda-Gail is one of the most approachable and engaged partners we have, and I know if you have any additional questions, she will happily field those in her spare time.
Indeed. Indeed. Thank you.
Great. Thank you so much. Have great days and evenings all, and we look forward to many more conversations.